So it gives me great pleasure in this evening's podcast to introduce Professor David Gozal. He's a world-renowned pioneer in the area of pediatric sleep medicine. He's currently the chairman of child health at the University of Missouri in Columbia, Missouri, USA, and the physician-in-chief of the Missouri University Children's Hospital. He's published extensively with more than 750 papers in reputed scientific journals and more than 150 chapters and reviews, plus he's edited 4 major textbooks. So Dr. Zoll, thank you very much for giving up your time to chat today. Can I maybe start by asking, for a lot of parents' understanding of this topic, why is sleep in children different from adults as far as the conditions such as sleep-disordered breathing or sleep apnea?
Well, first of all, thank you for having me in your program, and hello to all the parents who are listening. I think that the most important element that we need to remember is that the sleep needs of children are very different of those of adults. We're all familiar with the fact that a baby, when they're born as an infant, we need many hours of sleep, 14, 16, even though moms may sometimes only remembers all the time that they needed to wake up and feed the baby or change the baby. And certainly parents will remember those difficult periods because babies and infants have a different time cycle of duration of what we call the sleep cycle. But if you take the total amount of sleep that a baby needs, that particularly during the early few months of life, they need about 16 hours of sleep for every 24 hours of the day. So, which is very, very different from what a young adult or healthy adult requires, which is about 8 to 9 hours on average, 8.5 hours being the real median or average that has been quoted by many, many studies. So if we really take that as a guide, then babies need to sleep 3 hours on, then they wake up because their capacity to feed and their metabolic rates are such that they need to feed much more often. And so this feeding cycle and sleep cycle, which are so short, start slowly extending themselves until at some point in time during the first or second year of life, we see that they shift already to really the nocturnal pattern, like we are guided by light and so on. But globally, they still need 14 hours, 12, 14 hours of sleep. And that continues throughout development until about mid-school or at the ages of 8, 9, or 10, where actually the need for sleep is less. So that means that during that period, and we are going to get into a second of why that is so important, the sleep need is very important to secure, one, growth. We grow very, very fast during that period of our lives. Second, our brain is developing and reconstituting all throughout the growth period. And so these two require then a lot of energy. And in order to process all of this, we need a lot of sleep. And so sleep fosters deep sleep, or what we call delta sleep, which is when we see very slow waves in the electroencephalographic or in the brain waves, is a signal in which the brain is now producing a hormone that is very important, growth hormone. So we need a lot of that deep sleep as children in order to grow better and develop our bodies. And that is a period in which our metabolism is also engaged in that process of building the blocks of our bodies. At the same time, many of these features, both the dream sleep, what we call rapid eye movement sleep, or delta sleep, this metabolic sleep, are essential for the connections between brain cells and all the wiring that happens in our brain to actually form new connections, take away and prune, what we call pruning of these old connections that are not as useful, establish memories, do learning, etc., etc. So you can see that during that period of time where we need so much sleep, anything that would disturb sleep can have a very adverse consequences. The second period in which, somewhat paradoxically, we need more sleep, after mid-school comes adolescence. This is yet again a period of very, very accelerated growth. We see them grow during summers. It seems almost impossible. They had long pants when the summer started and the school finished, and then within 3 months, wow, their pants are by their knees, right? And oh my God, we need to go and buy them a new pair of pants. How do they do this? They need all these new shoes because the shoes are too small, etc. Well, the brain is also undergoing major changes because of hormones and because of this. So both, again, this period of time requires that adolescents, as opposed to middle schoolers, will actually need a much greater period of sleep. An accelerated, again, growth hormone is playing, but this time it comes with a twist. And the twist is that they become jet lagged, chronically jet lagged. And so because of hormones and many other things, their clocks get shifted to as if they were living in earlier times. So if you live in Melbourne, suddenly you're now living in Perth. If you want an example for Australia. So the same as in the United States, you live in New York and now your adolescent child is living in Los Angeles. And so they will want to go to sleep much later and they don't want to wake up at the usual times. And therefore they will want to wake much later, which is incompatible with the work schedules, incompatible with most of the school schedules. And so this creates a very significant problem. So, so you can see that before we actually even get to young adulthood, we have gone through 2 periods, at least very long periods of growth and development in which sleep is very intensely needed. You need many more sleep hours, and you need that for both growth of the body, but also growth of the mind, the intelligence, the memory, the intellectual capacity, and everything else. And those are, of course, periods of vulnerability. In other words, if something disrupts sleep, and sleep being disrupted may lead to consequences that are not necessarily the consequences that you would want to see in your child, because as parents or as pediatricians, what we want is not only to raise healthy children, but we want them to become healthy and productive adults. And so that is a conundrum that obviously we need to use sleep as one of the pillars of life and not see sleep as a expendable function, but more a very critical and crucial and cardinal function for everything that we do.
And can I then lead on from that? If parents suspect problems in their child's sleep, behavior, etc., how would they get an accurate diagnosis of sleep apnea in their children?
So this is a very important. So first of all, let's take a look at what happens if you have disrupted sleep. It happens for a variety of reasons. You could, for example, live next to an airport. Okay, and every plane landing or taking off will create a lot of noise. You live in a very noisy environment. You have by a train station with trains moving in and out, by a freeway. So this is what we call noise pollution. And noise pollution has been linked to a variety of diseases: cardiovascular diseases, diabetes, Alzheimer's, it's cancer. So you can see that even perturbations in chronic life of the quality and the depth of your sleep can have tremendous consequences even in adults. So now let's go to children. Okay, so what could be disrupting sleep? Well, first, if they don't sleep in what we call in a favorable environment of sleep, putting them in a very noisy environment, in a place where there's too much light, all these other elements, if the quality of their sleep is not very good, that can have consequences. There may be subtle consequences. But if you, for example, snore, so snoring, and we're going to get into it in a second, I will explain what could cause snoring. So snore is an indicator, a sound indicator of having some degree of difficulty to breathe, okay? We should not snore at all. But there's a lot of people and a lot of children that snore. And then one of the major reasons is because tonsils and adenoids, which are lymphadenous tissues within the upper airway, they grow for a variety of reasons: pollution, viruses, just infections, etc. All of these, allergies, and all of these can lead to these tissues to grow. But also, we may be born with a little bit of a smaller mandible, or may have some of the bones of our face not to grow the right way. So for all these reasons, our upper airway, the conduit to the lungs, may be a little tight, a little crowded. That explains also why children, when they're obese, have the same issue of snoring. And in fact, there are many, many times over the risk of having snoring and to have sleep disorders of breathing when they're in the process of sleeping. So snoring is a sign. It doesn't tell you that there's a problem. All it's telling you, hey, you are having a little bit more difficulty breathing, okay? Now, some kids do very well with it, but the majority will have times during their sleep that they need to wake up in order to catch a breath. When we go to sleep, our drive to breathe is reduced. The amount of effort that we put to breathe is reduced. The muscles relax. And particularly during rapid eye movement, that dream sleep, we all of us become, in a way, paralyzed, except for some muscles of our breathing. And so during that time, that relaxation may lead to a relatively tight airway that normally during wakefulness we can compensate, now is too small and therefore does not allow for enough air to go to the lungs. So now you have what we call an obstructive apnea, or that means that you have no airflow going to the lungs, or you have a relatively reduction in the amount of air. What does that cause? Well, it causes, first of all, that the levels of oxygen in your blood, in the blood of the child or the adult, will not be good. It means that the carbon dioxide will go up, which is also not very good. It has consequences. And then in order to resolve that problem, because you don't want to stay like this for a long time, you're going to wake yourself up. So what are the three things that have happened? Now you're working harder to breathe. Your levels of the blood gases, in other words, carbon dioxide and oxygen levels, are now not very good. And now you need to wake yourself up. That means that you have disrupted your quality of sleep. And instead of having the deep, high quality sleep or the dream sleep that you need, which is essential for brain development and many other things, you're not getting that quality of sleep. And so the brain will suffer, many other systems in the body will suffer, particularly in children that are during those growth periods, both the adolescent or the very young children that are undergoing those growth. The brain is maturing, is developing all of this, all of that may be affected and therefore manifest. So we have telling the parents, if you pay attention to your child and you hear snoring, then look for other signs that something is taking a toll on your child. That's what we call the snore plus. You snore and there's something else. So let's talk about these things. What could be the plus? Well, the plus is your child is tired in the morning when they wake up. No child should be tired in the morning and feel grumpy. Why? If you slept wonderful, the children should be happy waking up. And so if you have a very grumpy child, very difficult to arouse, if you have a child who is the teachers are telling you they have difficulty paying attention in class, or they're becoming hyperactive, and I'll get back to the hyperactivity for a second, in a second. If they complain of headaches, for example, when you have elevated carbon dioxide, you have dilation of the vessels, and that causes a headache. It will go away after a few hours, but a child waking up and says, "Mommy, I have a headache," and you hear this one time, and the second time, and the third time, you should be worried that maybe, and the child snores, something is not right. They may wake up in the middle of the night with a nightmare. They may have more night terrors. So if you see a lot of nightmares, the child wakes up with a nightmare or night terror or sleepwalking more often, then those are things that should alert you, particularly if they snore, that something is not right. Let's say that the child has bedwetting. after the age of 4 or 5 for boys, or after the age of 3 in girls, they should be dry. And if they're not, and they continue to have it, and you hear them snore, maybe there's a connection. And the reason is that if you are so sleep disrupted that you, every time that you're asleep, you want to keep asleep, then when you have those signals from the bladder that should wake you up and allow the child to go to bathroom, well, no way I'm going to wake up. I need my sleep because I can't breathe, and so I better keep as much sleep as I can. So it's okay if I do it in bed, and then whenever I wake up, I can call mommy to change the diaper, to change the pajamas, to change the bed sheets, and everything else. So those are all very important signals. But more serious ones. Let's say that you're in school and you were doing very well, and in kindergarten, your child was doing wonderful, but now first grade, now the grades are not very good, and you're having difficulty with learning, and you're having behavioral issues, and you're having misbehaviors in school, or you're becoming aggressive, or you don't care as much, and you're not playful as before. These changes in learning or in behavior should alert you that something, and the child snores, that something is not right. So I've given you a whole set of indicators that snoring with some of these may translate into a child not suffering from a condition that we call sleep apnea. Now, why are we talking about hyperactivity or ADHD-like attention deficit hyperactivity behaviors? Well, let's go back to the normal child, the completely healthy child. And now it's evening hours, I don't know, 7, 8 p.m. The child was happy all day. And after dinner, if you see that, you will immediately know when your child is sleepy, because they become wired. They start running around, doing all sorts of things, not listening to the parents, becoming sometimes emotionally very unstable. They start fighting with your brother with sister, brother with brother. They start being, and children, when they're sleepy, they become hyperactive. It's their way to stay awake. They fight staying awake by moving. And when you move and when you don't pay attention, it means that your area of the brain that is called the frontal brain or the executive brain, that area is become less controlled because sleep is suppressing that area. So all the normal mechanisms in the brain that allow for the child to be well behaved, well controlled, to sustain and be able to maintain attention are now being suppressed. And what takes over is the other areas of the brain that make the child try to resist sleep, becoming very impulsive, very emotionally unstable, very feisty, and then the child after they fall asleep and everything is wonderful. But imagine that every day, every night, you snore. You wake up 20, 30, 50, 100 times. You don't remember any of those. They're 3 seconds, 4 seconds, 5 seconds. We do that all of our lives. We do that in a normal way in order to keep our systems going. But if you do it excessively, like kids that have snoring or adults, it's like having a phone call every 5 minutes, 10 minutes. You wake up, nobody answers, you go back to sleep. Now, except that you wake up to breathe, you don't wake up to anybody else calling you. It's your own call from your own throat, from your own breathing. And so at the end, when you wake up in the morning, I don't think that you're a pleasant person. And how do you expect a child to be a pleasant child? How do you expect them to go to school and listen to the teacher? How do you expect them to pay attention, to learn, when they have not been able to sleep very well? They have had what we call fragmented or disrupted sleep. And on top of it, we know now from a lot of experiments that we and many others have done, that if the oxygen levels are not good, in other words, they go down, the brain is very hungry, very thirsty for oxygen. And so these brain cells will suffer, and some of them will start dying. And when they start dying, you start losing brain cells, you start losing IQ, you start losing the ability to learn, the ability to memorize, to do all the things that we need. And so that brain that is so vulnerable, remember, you need more sleep because you're a child, you need more sleep because you're an adolescent. Now that brain is going to suffer even more. It's more vulnerable, more susceptible to these changes. And so you start losing all these brain cells in specific areas of the brain that are particularly labile or unstable. And therefore, you may start losing IQ. And so we have done studies, and others have done in all over the world, where they showed that on average, if you have moderate or severe sleep apnea, you may lose up to 8 IQ points. Now, what does that mean? Well, all of us, on average, the average IQ is 100, okay? So, but we all think that our kids have IQs of 200. So if you were to lose 8 IQ points in a child with an IQ of a genius, nobody would notice. But if the majority of the children are born with an IQ of 100, and you lose 8 points, that makes a huge difference in school performance, in academic performance, and so on. And so it is important to remember, one, the brain is much more vulnerable because our children need more sleep. It's vulnerable to disruption, and it's vulnerable to lack of oxygen. And these are two of the situations that are created by the presence of snoring and of sleep apnea. And so sleep apnea is a serious condition that can lead to significant deficits, to significant problems, both in behavior, but also in intelligence, in cognitive performance, and ultimately in the ability to succeed in life, because we need as much brain as we can and as much intelligence and education as we can in order to succeed in life.
And can that lead on now to, if the parent has the correct diagnosis and they've worked with their medical GP, sleep physician, etc., and the diagnosis comes back as sleep disordered breathing or sleep apnea, what are the current treatment opportunities available for their children?
Well, like everything, what we aim to accomplish with every child is to deliver the best personalized treatment with the minimum risk involved in that treatment, okay? So always we need to think of risk and benefit of what we do, and to take away the disease that is causing consequences, but at the same time do that with a minimal risk, with a reduction of risk associated with it. At this point in time, when depending on the severity of the disease, those that have moderate to severe disease, if they have enlarged tonsils and adenoids, the first line of therapy is usually to take those tissues away. In other words, to do a surgery that will remove the tonsils and will take away some of the larger adenoids that occupy and block some components of the airway. Now, that does not mean that it will be the only treatment that is needed. A proportion of these children will completely normalize their sleep, but others will not. And so we will get back to that in a second. For children with milder conditions, we may, for example, use, instead of doing surgery, we may use anti-inflammatory therapy that is given as sprays to the nose or other treatments. And this will be guided by the sleep specialist or the GP. And then need to see what other contributors may be there. For example, let's say that the mandible is now very well developed. So you may need to do, through orthodontic therapy or through other therapies that are done by specialized dentists that are specialized in sleep medicine, to do the expansion of the airway in order to facilitate the growth of that airway to its maximum potential, so that the child can breathe and have no evidence of this obstructed breathing that is affecting all these functions and growth and quality of life. By the way, I should indicate that the quality of life in children that suffer from sleep disorder breathing is markedly affected. And to give you a perspective, it is the equivalent of children that suffer from cancer on chemotherapy. So it's not a joke. In other words, the quality of life of a child that has sleep apnea is equivalent to that of a child with cancer receiving chemotherapy. That is not a joke. Now, except that we would say, oh my God, the child with cancer, poor kid, is suffering through the chemotherapy and all the side effects. And of course, their quality of life is going to be terrible. And yet we do not realize that the child that we have at home and that supposedly is fine except that they snore and have sleep apnea, is actually having the same impact on their quality of life. So coming back to therapy, there are multiple instances in which there needs to be a multidisciplinary care. And so as I indicated, for moderate to severe, probably taking the tonsils and adenoids is going to be the first line of therapy, but that does not imply in any way that all of this will be solved. So it is always good to follow up. And then if there is what we call residual sleep apnea, or in the children with more milder that does not respond to the initial intervention, that is anti-inflammation, then, as I indicated, you may want to do a rapid maxillary expansion. You may want to train the muscles of the airway, so what we call myofunctional therapy. You may want to do some degree of, for those that have their mandible that is not very well developed and small, you may need to do a more aggressive therapy. And we have, for example, babies that are born with certain conditions that their mandible is very small. And so those really, just as a life-saving procedure, they may need to have expansion of the mandible using very sophisticated surgical techniques. And so the overall range of treatments that is provided is becoming intensively expanding. And I think that it is really the collaborative multidisciplinary care that is very essential in order to personalize, because each child is different. The contribution of the different elements that lead to this breathing disorders when they're asleep needs to be tailored to the exact reasons for which they suffer, such that at the end, the result will be the one that we want, that the child will be able to breathe uninterrupted with high quality of their sleep and without having any of the things that we talked about. No reductions in oxygen, no elevations of carbon dioxide, no excessive work of breathing during the night, and certainly not all the awakenings that then lead to this disrupted sleep. All of these together are elements that we do not want to see in any child in order to promote their well-being, their quality of life, their growth, their idealized and optimal growth, the normal development of their brain to their maximum potential, and everything else that could be affected in the process of growing as a normal child.
I mean, it's very topical. In Australia, recent stats have shown we have one of the highest rates of teenage suicide than any other country in the world. We also have per capita some of the highest usage of Ritalin. If a child in Australia, or a parent of a child, is told your son has ADHD and put on medication, should they be, before accepting that diagnosis, at least having a proper sleep study? Or what is the best way to evaluate the genuine ADHD versus possibly the very similar symptoms associated with poor sleep?
Yeah, the distinction is very important here. And so there are multiple professional scientific associations that have issued a set of guidelines based on very serious studies, whether it's the American Academy of Psychiatry. I'm sure that in Australia there are equivalent guidelines that have been issued by very knowledgeable individuals. The same is true for the American Academy of Pediatrics and many other associations, professional associations, that have issued a set of guidelines, of a menu, if you wish, a pull-down menu of how to evaluate a child that has symptoms of hyperactivity and inattention. And so let's say that after this very thorough and comprehensive assessment, which cannot be done by a GP, and I'm going to emphasize this, it requires a neuropsychologist, a developmental neuropsychologist, extensive testing, a psychiatrist, the reports from the school, reports from the parents, an observation period. And so this is a very time-consuming and extremely onerous, very expensive. And so it is usually reserved for the more serious or the more severe cases, rather than be applied to the 8 to 10% of all children that present with this inattention hyperactivity. So only a very selected few actually go through all this process. and ultimately are diagnosed with true ADHD. So when we take the true ADHD, what we call the real severe ADHD, then the prevalence or the amount, the percentage of these children that has sleep disorder breathing is the same as the general population. Okay?
Mhm.
But that's where the problem lies, because when you have other symptoms that are not as severe and your diagnosis of ADHD is based more at the GP level, and this is not a criticism to the GPs, it's just that it's or they're overworked, there would be not enough child psychiatrists and child psychologists and everybody else to do all children. And so parents come and says, you know, my child, the teacher said that he's not attentive, the grades are coming down. And if you ask those that are before they're put on Ritalin or some of the stimulants, what we call psychostimulants, about 30 to 40% will actually snore. So asking a very simple question, does your child snore when you have these behavioral issues, would automatically lead to a very significant proportion of these children at least going to a sleep specialist, getting studied and see whether they have any type of sleep disorder breathing. And if they do, treatment of those conditions will, in the vast majority of cases, improve on the symptoms of inattention and hyperactivity without necessarily having a need for medication, or if they need a medication, to have much less medication and be able to control the symptoms in a much better way. So what I'm trying to say is that the presence of sleep disorder breathing is one element that parents should be alerted to, because before you start medication, or if the child does not really respond very well to the medication and the child snores, you should make sure that, one, you check for the presence of disorders of breathing in sleep, and two, that you treat them, because this could be at the cause of some of the issues of behavior or inattention or hyperactivity that your child is suffering from, or the lack of response to the medication, the psychostimulant medication that your child has been put on, but nonetheless, it doesn't seem to have the desirable effect. So for all these reasons, we need to remember that sleep, or the actual lack thereof or poor quality of this sleep, can be determining factors for behavioral manifestations, behaviors such as inattention and hyperactivity, which then may be confused as being part of the ADHD, when in fact they are the cause of these symptoms. And when you solve the sleep problem, you eliminate or at least markedly improve the behaviors to the point that you may obviate, you may preclude the need for putting many of those kids on the medications that otherwise they're going to be on.
And could I just bring up the topic of sleep latency? So say a child doesn't necessarily have poor sleep. When they get to sleep, they sleep soundly, they wake up quite refreshed. They don't have daytime somnolence, but they just have the difficulty getting to sleep. Any suggestions where a parent goes in that regard? So they put their child to sleep, they come back an hour later, the child's still awake. Uh, I know some people kind of nowadays self-subscribe melatonin, etc. What would you recommend for parents who have that sort of child?
So first of all, you're not alone. As a parent of a child who has what we call bedtime resistance or difficulty falling asleep, these are very frequent issues, and more than 15 to 20% of children at one time or another have these symptoms. We actually, along with one of my colleagues, Dr. Lisa Medali, we have put a book for parents, which is quite cheap, called Putting Bed Problems to Sleep, because we give scenarios that really many of the parents will relate to, and provide a set of guidelines as to each one of these scenarios, as to what are the things that parent can do in order to at least troubleshoot this problem and find a solution in the majority of cases. Now, because of what we see is a lot of confounders. The first is we start with the baby. The baby cries, we lift the baby, we shake the baby, we rock the baby, we cuddle the baby. Well, the baby needs to learn self-soothing. And yes, I'm not saying that we should do what with Dr. Ferber, Dick Ferber at Harvard many years ago advocated for what has been termed as a more nickname of Ferberizing your baby. In other words, letting them to cry until they finally fall asleep. We do not advocate for that any longer. We believe that there are much better ways of bringing as a positive reinforcement what is going to be helpful to the baby and not associate a traumatic separation to, but we can establish presence without necessarily lifting the baby. We can put a reassuring hand on the baby, but without lifting. And babies will progressively learn that if you're there and then you're at the door, and then they learn how to do it on their own. And this self-soothing is a very important facet of teaching children or babies how to assume sleep on their own without the need of parents. Now, there are children that are more anxious. There are children that have a variety of conditions. For example, if you are exposed to screens, today it is very frequent, iPads, TVs, telephones, computers, all these emit a lot of blue light. And what these kids are doing, what these children are doing is engaging in a variety of games that can be quite stimulating. Well, I mean, if you are having a great deal of fun, it is very difficult now to settle down and suddenly automatically, just by virtue of, okay, kids, time to go to bed, and now let's go sleep. Well, sorry, it doesn't work this way. So there must be a very, what we call soothing routine, a settling down routine that needs to be implemented. We call this sleep hygiene. And it needs to be aligned with the circadian clock in which our children need to live. So first, I said routine, and that is critically important. In other words, a routine means that every day is the same or every time is the same. So if you one day go to sleep at 6 p.m. and the other go at 11 p.m., that is a very bad habit because you're disorienting the whole system of the child on when the actual bedtime is. So it is very important to be very consistent, to be very regular, to do things in a very regular fashion. You have your shower or your bathtub, you have your meal, you have a book and a story, you put maybe a weighted blanket or something that the child likes, to have a little toy or a stuffed animal or whatever it is. The environment that is conducive, the temperature is not too hot, not too cold, there's no need for lights in the room. And you create that environment, and that environment is consistent. It's always at the same time, always following the same routine. These children will, their body, their systems will learn how to go to sleep. If you have very erratic, very disorganized lifestyle, one day you go like this, tomorrow we're going to do an exception. After that, you go to sleep in the sofa. The next time you sleep in the bed. The last time you put in front of the TV. And this is normal modern life. I'm not criticizing. I'm not saying anything. So how do you expect a child to learn a routine and be as accurate as a clock so that finally the parents can go to sleep if you do not advocate to create that routine that they need in order to be as predictable as possible? And so we need to think of those terms. Remember that younger children, even though they may not be able to fall asleep whenever they need to, but they are going to catch their Z's. They will take their naps, they will do, but it's the parents that are going to suffer. Because at the end, you have your obligations of going to work, you want to have your evening. And so if your child is not allowing you to sleep through the night, wakes up in the middle of the night and seeks attention because they cannot sleep soothe, because they cannot go back to sleep on their own and come to your bed and wake you up and start crying and doing all that, you are going to be, as a parent, the one who is disrupted. And next day, you're the one I don't want to talk to because the child will have caught up with their Z's at whatever time. And so they will do what they need to do. But you as a parent are going to carry all this chronic sleep deficit, which is going to make you a very grumpy person, to say the least. Let me put it this way. And difficulty functioning, emotionally taxed, and we know the frazzled parents that come very often to our clinics because their child did not go through the appropriate training and routine that ultimately enabled them, one, to fall asleep, and second, to soothe themselves back to sleep when they wake up in the middle of the night, which is all the children do that, all of us do that.
Dr. Gozal, if I have time for just one last question. In Australia, when the original diagnosis is made of sleep apnea, the common treatment is CPAP therapy. And I know when Christian Gumenor visited Australia and addressed our sleep study, our sleep society, he was quite adamant that a child should be taken off CPAP as soon as possible because of the long-term consequences are possibly associated with facial growth. Do you have any comments on the role of CPAP in this situation and duration? And if so, how can a child be weaned off CPAP?
So first of all, CPAP is reserved for a subset of children that do not respond to the other measures that we talked about. Those children will require CPAP for as long as their breathing is obviously affected during their sleep. So our aim is to shorten that period of time as much as possible. Let's say that if the child is obese, to make sure that we provide guidance on exercise, physical activity, diet, and guidance so that together this child will benefit from potentially reducing their weight. And if the weight is one of the contributors to the sleep apnea, then make sure that the CPAP can be stopped as soon as possible. Similarly, if you're going through an orthodontic therapy or through other elements which take time, that once the airway has grown and developed, maybe it's possible to reduce the CPAP and to stop it altogether. So these are things that we test usually on a 6-month or annual basis, and depending on the conditions and the time, we will do whatever is necessary to stop CPAP in the majority of children as soon as that is allowable. And the sleep study without CPAP shows us that the breathing is normalized and that therefore the risk is not there anymore and the need for the CPAP is not there.
Thank you very much. Thank you very much for your time this morning. I'm pleased to say that as of last week, Australia is now finally open for international travel. We've been shut down for a long time. We would love to have you address our sleep association. I know it's very, very difficult to book you in advance, but I'm hoping that we will see you in Australia because the research you've done, the information you've given, not just for professionals, but also for the parents, is world-renowned. And I think it's brought to the forefront for everyone the importance of treating these children early so that they don't have you said in the past, this catch-up period of time or the loss of the neurons, etc., etc. So thanks very much for your time. I appreciate it. And we look forward to seeing you down under as soon as possible.
I look forward to it as well. Thank you very much for having me, and see you soon.
Thank you very much, Dr. Gozal. Bye-bye.
Thank you. Bye now.